Hi, everyone. My name is Catherine Hoover. I have the pleasure of introducing our speaker, Dr. Samantha Casselman. But first, I would like to promote a few of the SDNP's initiatives, including a request for presentation proposals. The SDNP is committed to the creation of educational content, both live, like this webinar, and on demand, for dermatology nurse practitioners to earn continuing education. We strive to provide Derm NPs with the credits that they need to renew their DCNP through the Dermatology Nurse Practitioner Certification Board. We also hope to provide Derm NPs with the opportunity to share their expertise and to build their resumes. It also doesn't hurt that there is an honorarium. So please check out a request on our website. I would also like to encourage you to check out our new job board. It is free and open to the public. You are welcome to share these posts with friends and colleagues. Now let's get to the main event. Dr. Casselman is a pediatric nurse practitioner in Phoenix, Arizona. She has worked in pediatric dermatology since 2013. She is an experienced national speaker on the topic of atopic dermatitis and partners with the National Eczema Association, the largest patient advocacy organization for eczema patients and their families in the United States. She is the founder of the Dermatology Special Interest Group in the National Association of Pediatric Nurse Practitioner Organization, and owns her own practice, Happy Skin Pediatric Dermatology. I'm now going to hand it over to Dr. Casselman. Please hold your questions until the end.
Hello, thank you so much for joining live today. I apologize if I get in a coughing fit. I did just get over from being sick. Fun times when you have presentations to give. But I am really honored to be here and giving you this presentation with the SDNP. And my primary focus in my clinic is eczema, atopic dermatitis. So I will be talking to the audience as if you know at least a bit about eczema, but we will go over at the beginning a little bit more in depth in case we have any learners or any students who are interested in just knowing exactly what we're talking about when we talk about atopic dermatitis and the treatment and the pathophysiology. So this presentation is the Eczema Audit. It's a systematic approach to education and management of AD, and we will get started. So to disclose for you, I have a few. So I have partnered with Sanofi as a consultant and a speaker. Also Pierre Fabre is a consultant and a speaker. The National Eczema Association as an invited speaker. And I still left the Pfizer consultant and speaker disclosure there, even though it ended in 2020. I wanted to put that there because it was related to one of the medications for atopic dermatitis. These are the learning objectives that we'll go through. I do want to do a high-level overview of atopic dermatitis treatment and my recommendations. I want to also illustrate any educational plans and materials and ideas that you might not have thought of before, and just reflect on ways that we can help these patients in a more holistic approach. So first, let's discuss just generally understanding atopic dermatitis. So if you are in the dermatology camp, which I assume most of you are, then most of us do really feel that that root cause, which a lot of our families are going to be coming in and asking us about, I want to get to the root cause of my eczema. Well, unfortunately, in the dermatology camp, we really feel that it's genetically based for the most part, because there may be either deficiencies in filaggrin with this increased risk of having AD or related symptoms because the other family members have atopic conditions. But it really starts with that weakened skin barrier, the dry, cracked, easily damaged skin barrier that becomes inflamed with environmental triggers. And then when you upregulate that inflammation and the pathways that we're now learning so much about with that targeted therapy that we have available for atopic dermatitis, and that increases the inflammatory response, and it also thickens and disrupts the inflammation process with the skin barrier. And so it's this very nasty cascade of issues that happen. And then because the skin barrier is open, then you have an increased risk of an allergy development. But I'm not necessarily talking about an allergy to a peanut. I'm talking about a delayed hypersensitivity reaction, the type 4 delayed hypersensitivity reaction that can occur when you use certain skincare products on your skin. That's a whole nother discussion for an hour or more on different contact dermatitis causes. But in the dermatology camp, while there are other things to consider, whether it be GI related or whatever other comments that our patients may give to us, this is the exact flow that I will give to my patients of discussion when I meet a new patient for an appointment. That genetically based, your child has a propensity to have a drier skin barrier, which will cause these other problems. And it'll be really common in your HPI findings that our patients are very young when they develop AD symptoms. So it's not that a patient who comes in at a later age doesn't have atopic dermatitis. It just might not be the first thing that I think about if they've never had any rashes like this and they're coming into me as a teenager. The skin will always be reported as being dry, inflamed, itchy, itching being that real key, and then potentially with that history of infection, or a lot of parents tend to recognize impetigo rather than skin infection. And when children are younger, they have that unfortunate area that can cover all of their body, but particularly on the cheeks and forehead, scalp, and extensor surfaces of the arms and the legs. And as kids get older, then they tend to move into those more flexural areas of the neck, the elbows and knees, wrists, ankles. And that's not to say that younger children can't have AD in the flexural areas when they're younger, but it tends to be a little bit more synonymous with older kids rather than in babies. Their cheeks are really severely affected because they get all sorts of nastiness on their face with saliva and food and snot. So babies, unfortunately, will have a broader BSA coverage. And parents will often tell you that maybe they don't know a particular trigger, but there's this relapsing course that comes and goes throughout the year. And it's really common that both the child, depending on their age, and the parents or in their family, that they have a history of one of those atopic conditions, eczema, allergies, or asthma. And just some clinical pearls that I've noticed along the way, again, more for maybe some of our more novice peds derm people, is that AD can typically overlap with seborrhea in infancy. Those areolas and nipples can get really inflamed and quite swollen, and they tend to get infected and weep and get crusted. So that can be a really common finding. Maybe it's just easy because they could scratch on their chest quite easily. And then darker Fitzpatrick types and black skin, the skin can look really papular. It can also be, the AD can be very follicular based, and then their skin and skin of color, it could be quite different, not necessarily having those bright red tones that you're used to with a lighter Fitzpatrick type, but more of a bruising or a purpley appearance. And then lymphadenopathy can be really common in patients when they have more of a full body AD. And if kids especially have been biting their fingers, or they tend, unfortunately, they'll kind of like bite them to scratch them. And if their cuticle is absent, then they will develop some nail dystrophy down the road. Prurigo nodularis is just those thickened papules from chronic scratching. And then it will be always common for kids with skin of color to have post-inflammatory hypo or hyperpigmentation, and lichenification, which is that thickening of the skin, which looks, I tend to describe to parents as almost like a callus appearance. So moving into my recommendations. So skincare for kids, I am pretty strict if I'm dealing with a moderate to severe atopic dermatitis patient. When they are flaring, then I don't want them to do any fragrances, which is really common for parents to know, but I also want them to be botanical free and food free. So because so many of the products have oatmeal in the products, or they have different plant-based ingredients in products, as many of the eczema cleaned over-the-counter products will have many different plant-based products in them. I don't necessarily always discourage that in families, but I do ask them that when the skin barrier is open, that they don't use those products that have those ingredients. They need to be more hypoallergenic, very basic with the ingredients when they're flaring. And if they really want to use these products when they're not flaring, they could spot treat and they could test the site and see if they cause any problems with flares. Every appointment, I go over the type 4 delayed hypersensitivity reaction that can happen from using these ingredients in skincare products. And most families, I'd say probably 99% of families, don't realize that they can be causing a problem. But if you think about it, the skin is our largest organ in our body. So if you have an open area of skin, you're putting an ingredient on it that has, say, a plant, but the patients are at risk for developing allergies to plants, then why would you potentially be increasing your risk of developing that allergy because it's absorbing into the skin from your skincare product? So I steer them towards ceramide-based products. I have no stock or claim or a preference really for any particular product besides the fact that CeraVe has ceramides in most or all of their products. So CeraVe tends to be my go-to for the ointment and the moisturizing cream. But there are many other products that have ceramides in them. So I ask my patients to use a ceramide-based product, soaking in lukewarm water for 5 minutes daily, because a lot of families, especially with babies, will either not be bathing at all because their primary care provider has told them not to bathe. I'm sure a lot of you can raise your hands and clap because that's a really common history that we get with our more moderate to severe patients. And I ask them to use a liquid cleanser for cleaning. And then using an emollient head to toe when the skin is still damp, that kind of soak and seal concept that you hear about. And all of the moisturizing really most important within like 3 minutes out of getting out of the bath. That way you don't evaporate that moisture out of your skin. I also ask them to focus when they're flaring only on utilizing ointments, because ointments do not have alcohol in them to preserve them. However, creams do. So if a family is, say, used like a CeraVe moisturizing cream, a lot of times when kids are flaring, if the families are still using those creams, then they'll say, oh, that stung and burned, or it seemed to hurt them after they put it on. And that would happen with any cream, because creams, both over the counter and our prescriptions, are preserved with alcohol. So you're going to have that stinging sensation with the cream. So I do focus a lot on families really using only ointments when we're flaring, and then they can go back to the creams at other times. Then we get into the discussion of treating inflammation. We need to stop that inflammation cascade from happening. So this isn't a discussion necessarily about treatment, but you could be offering options for topical steroids, topical calcineurin inhibitors, PDE4 inhibitors, or biologics, depending on the age and the severity of your AD. But that's really all based on clinical judgment and patient and family preference, because many of my patients who come to me, they already have steroid phobia. So I can't go at them with just this generic canned type of a treatment plan, because I'll lose them if I just say, oh, use the steroid again. There are other non-prescription based recommendations that I found are really helpful for patients, dilute bleach baths being one of them, cold ointments kept in the refrigerator, certain types of probiotics, even traditional Chinese medicine has been really astounding for some patients. And then even changes in diet, however, with the guidance of a nutritionist and with an allergist, depending on if we're having concerns for food allergies. So again, not the focus of the discussion today with how we will treat, perhaps it's another time, but I want you to consider that the two go hand in hand. Your prescriptions and your non-prescriptive treatments need to be all in that same discussion. So by this point, you've probably spent at least 15 minutes with your patient, but add in at least 5 more minutes, 5-10 minutes. If you have much longer, then honestly, a lot of my new patient appointments for atopic dermatitis will go well into 45 minutes to 60 minutes. Granted, I have my own practice. I schedule at least 45 minutes with my patients because I don't know how long we're going to go into a discussion. So I am sensitive to the fact that you may not be able to have this type of time with your patients. But if you do, then I really encourage you to build in the concept of treating the whole problem. So we have to discuss infection, both training the family to prevent and recognize infections. We have to control the itch. We all know that the itch scratch cycle, in my opinion, is the driver for very severe atopic dermatitis in a majority of my patients. We could do that with antihistamines, anti-scratch clothings, and even bringing up counseling for cognitive behavioral therapy or family counseling, because these are problems that we as parents don't plan to take care of for our patients. So it's not going to be effective to ask the patient to stop itching, stop itching. Sometimes we need just a little bit of help and guidance from somebody else so that they can have what they feel as like a toolbox of sorts on how to mentally treat their patients, their kiddos AD from a behavioral standpoint rather than just a treatment only standpoint. Then you have to discuss sleep, especially in young children. The studies that we have for sleep and atopic dermatitis show us that our children are not getting down to that deep REM quality of sleep when you have moderate to severe atopic dermatitis. So sometimes we have to use sedating medications. We have to encourage good sleep hygiene. A cold room is going to be best with breathable clothing, and really emphasizing the importance of restful sleep. So if you have a parent who feels really guilty because you're asking them to give them a sedating medication, kind of add in those comorbidities that can happen that we now know are really prevalent with our patients with AD. Not only our patients, but our patients' parents actually have an increased risk of having anxiety and depression compared to the remaining population when they have a child with atopic dermatitis. And then those children can go on to have anxiety, ADHD, OCD, heart problems, like all of these, so again, not the discussion today, but those quality of life issues, those mental health issues are really quite drastic in our patients with moderate to severe atopic dermatitis. There was one study that I read that was really shocking to me, that the quality of life burden of atopic dermatitis patients was right alongside a cancer diagnosis. It affects the whole person, the whole family, and that negative quality of life burden that AD has on them can really, in this study, be just right there with alopecia, bad psoriasis, cancer. So kind of help to frame for your families that this is something that medically we're needing to help them with sleep, and that usually really helps parents to feel better. And also ask about their mental health. So give them ahead of the appointment one of the CLDQIs or the POEMs. Those are both quality of life measures that a parent or the patient would fill out. And that gives you a really quick snippet of like, oh, wow, maybe you're only seeing a severity of mild, but their quality of life is like severe off the charts. So you need to address that with them. When I was doing support groups with the National Eczema Association, I've been working with them now for 4 years. Every age group that I've worked with for parents, so it's broken down by babies to 5-year-olds and 6 to 12, and then the teenagers. 1 year, every single age group had a parent who said that their child had either had a suicidal attempt or ideation in some way, shape, or form. That was just heartbreaking to hear and very eye-opening. One mom shared that if I didn't bring up in an appointment the fact that you could have depression and anxiety from atopic dermatitis, then she would think that that was just something very specific to her child and not necessarily specific to atopic dermatitis. And therefore, by making it real and by bringing that up from a medical standpoint, she said that that was really helpful when her provider did that for her, because it made it a real issue that you had to tackle rather than just that mom thinking that it was only her child's problem. And refer, obviously, when indicated, to a mental health specialist. So now we'll go over what I call kind of my eczema audit. So alongside figuring out what I'm going to treat for my patients and what type of educational, materials do I want to go over with them, what I've developed in my clinic is really this holistic approach to assessing, treating, and partnering with families for children with atopic dermatitis. So first of all, I'm going to recommend that you seriously automate your practice. So I am a one-man ship. I left the Children's Hospital that was here in Phoenix because I was frankly burned out. And I opened my own practice because I wanted to be able to meet parents and families where I felt that I would have the most effective treatment and partnership with them. But because I'm just me, myself, and I really had to find how to automate my practice. I am, also an IT clinical analyst. So because I had that kind of comfortability with different systems and automation, maybe I have a little bit more of a better chance of doing this successfully. But this is why I want you to be able to take this piece of the eczema audit and move it into your practice. So creating screening questionnaires ahead of time that the patient gets. And if you could automate that as soon as they make a new eczema appointment, then send that out. You definitely want to grab photos ahead of time. As many of you know, we could all probably just look at photos and send a diagnosis and treatment right away, but AD just takes a little bit more counseling and discussion. And then once you're done with the appointment, then already have your laid out educational materials that you're going to send to them right away. Have them queued up in your files, saved on your desktop, send it right away, because you don't want to accidentally forget to send them something important and then go on to your 15 other patients and not have sent them the material that really will help them grasp these concepts at home. So I'm going to review with you my intake form. So unfortunately, it's not something that I could send to you because it wasn't a Word document. I had to build these and all of the different like radio buttons and checkboxes. So this is how it starts. I want to know what age that the patient developed AD. I want them to click every location that they have eczema. I want to know what they think is a trigger. I want to know if they've been hospitalized for their eczema, if the child has had a history of asthma or reactive airway disease, if they have seasonal allergies, or if they've tested positive to any food allergies or environmental allergies. And I want to know what type of testing they've had. So was it just blood testing or was it skin prick testing? I want to know if they have an EpiPen and if they follow any particular diet for their child's eczema. A lot of elimination diets are happening, use of probiotics, which is great. Sometimes they're using some supplements. And then I want to know if they've had any allergic reactions specifically to foods. Then I go on to wanting to know about infections, whether they've been treated with topical antibiotics or oral antibiotics, if they've been diagnosed with MRSA before, because perhaps I need to go over staff precautions with them. I know that this typo is here, so no need to let me know. For some reason, my EHR doesn't like apostrophes. But I want them to know, I want to know if they've done the loop leach fast. So yes, no, or no, are you crazy? I've definitely had maybe 25% of my patients answer, no, are you crazy? So that's a fun discussion to have. If they have any trouble with sleep, and then if they have significant challenges during eczema flares for the entire family, kind of touching on those different quality of life aspects with school, behavioral challenges, if they've noticed anything related to skincare products that are causing them flares. This point here is what I utilize as my first kind of a kickoff point. So I have the history questions. I look at the kiddo and I say, oh, I see that a lot of people in your family have had eczema, allergies, or asthma. We really feel that it is a genetic based kind of like dry you out, make you very sensitive type of genetic based condition. And so that really is able to lead me into the discussion, really focusing on, well, that is the root cause. I can't change the genetics of your child. So let's work together to try to get a better handle on it. But I also preface that with, I am not a miracle worker. And the fact that I'm not the one and only miracle worker is that, we can't achieve 100% clearance. So really setting up those expectations is very, very crucial. Then I want to get into knowing what they use for skincare products and what they use for treatment. And parents have been really great. They've listed out specific ones. I ask them sometimes to bring pictures of their products because, and then we look it up in the appointment. I look up the type of product and then look at the ingredients and then use that as a teaching point to say, oh, like this product here has like 3 or 4 different botanicals and flower products in there. Maybe we want to steer away from that during flares. The laundry detergent oftentimes gets families for some reason because a lot of them are only washing their child's laundry. But if it's a baby, then we're holding our babies and then they're using the parent's shirt to scratch on. So that's a big teaching point when I'm looking through my screening question. If they say yes, but only for my child's laundry, I want to know how often they bathe. And then I want to know specifically. So raise your hand again if you've ever had a parent say, oh, I've used the white tube, I've used the white and blue tube. I just spent the time to lay out all of the topical steroids and non-steroidal options. So hopefully they could easily click and I will know exactly what they've used because once I know what they've used, and I either know, okay, we're going to be maybe using the same things as they've already done, but a lot of times they're using the very weak topical steroids before they come to see me. Again, kind of knowing how long they've used their medications, what they're currently doing. Oddly enough, a lot of parents, and maybe you again can relate, they come to the appointment and they haven't been using anything for like weeks for whatever reason. Or they'll stop a few days before just so you can see like how bad the eczema looks. And then I get into wanting to know, do you worry about using topical steroids for eczema treatment? And that honestly has been about 90% of my parents say, yes, I am worried about using a topical steroid. And then I want to know if they've used an action plan before to know if they're familiar with that. Probably only one patient had used that, and that's because they came from my own practice, my old practice, where I'm the one who created the eczema action plan for the whole practice. And then, very specific questions. So that's the first thing that I want to address with them for the most part in our appointment, because number one, I don't want to brush over their specific questions. But by the time we're done talking, tend to forget. But I want to know, like, just generally, is there anything else that I should know before we end the visit? And if you get this information before your appointment, then many of us could look at that in less than a minute. Exactly what we're going to do for treatment. We're going to have some red flags if they're not bathing, if they have had infections, but they don't want to do any bleach baths or haven't heard of bleach baths before. If they're afraid of topical steroids, that's going to steer your treatment in certain directions. And so developing this really comprehensive screening tool before the appointment for your new patients, I find has been very instrumental for me in my current practice, because this was these were not completed before the visit in my old practice. And now having that experience of your standard type of clinic versus my own practice, many parents will send this to me several days before, or at least the morning of. It's been so helpful and time saving for my workflow. And next, I want to talk to you about infographics and handouts. So this is an example of a daily goal that I created for one of my younger patients. And these little boxes represented check marks. So my hope was that the family would print it out, they would keep it on the fridge. For my really fancy, like Pinterest type moms, maybe they would laminate it and they would use a dry erase marker to do these kind of goals of every day using a moisturizing, taking the probiotic. This child was on Allegra. They also had a history of MRSA, so we needed to do staph precautions every day just because I wanted to get them on like a good routine, but obviously we don't do staph precautions every single day. And then choosing one sleeping medication every day because they were having a really hard time of just being okay with using sedating meds. And then there were certain things that I really wanted them to do. I really wanted them to make an appointment with the allergist, try apple cider vinegar for ingesting, and then they needed to start clindamycin because it was like their second time with needing a treatment for infection. So this is something I just made on Canva. I also made this presentation on Canva. And even though I do have the background in IT, it's a very easy website that you can use. You could also use something like Upwork.com and go on and find people who make infographics. So it's a repository of individuals who have different skills. So you can hire somebody to put up a TV from Upwork, or you could hire somebody to make one of these infographics for you. I actually utilized somebody to make my logo. I only paid like $30 for it. It was amazing. So Upwork is a really great site that you could utilize if you're interested in developing something like this, but maybe you don't have the time to do it, or maybe you're opening your own practice. That's super helpful. This is just a screenshot of a presentation that occasionally I use for my families. So I intentionally use Zoom because I want to be able to screen share. And so for some families, I find that it's really helpful to have a pathway for our discussion. So this is an example of a presentation that I've made. Eczema management, just getting it under control. And so I have different pictures of products that I want to use, different areas of the body, and different pictures of the topical steroids or the treatments that I want to use. So this did take me a bit of time, maybe about 2 to 3 hours or so. But this is something that sometimes I like to be able to send to families after the fact. Maybe they have a lot of other questions that are a little more unrelated to what I need to go over with them. So you know what, I will send this presentation to you so that hopefully you review it and you better understand the treatment plan that we have. Then if you haven't heard of an eczema action plan, they're really similar to an asthma action plan in the sense of the green zone, you're doing really well. The yellow zone, you need to kind of pause and start to think about what you're going to do for treatment. So that's your flaring zone. And then the red zone is you are not doing well. You need to get on the phone and call somebody because things are blowing up and you need to let us know so that we don't get to the point of hospitalization or needing to do wet wraps or needing to do oral antibiotics. So this is a screenshot of the array of eczema action plans that you can find on the web if you just simply type eczema action plan. But the one I want to highlight for you is one that you could actually utilize and edit to utilize in your practice. So this is what I utilize for my old practice. I wrote them here in Bristol, they're in the UK. I wrote them and gave them kind of my edited version of the eczema action plan, got their permission. It was a really simple process, but you can use this link to get to this article here, their process of developing a written action plan for kids with eczema. And this link down here is the link that you can use to get to their eczema action plan. And again, they have the PDF version and they have the Word version. So I still utilize this in my practice. I've tweaked it for my own practice now, which really isn't much different from what they've developed. But I do want to make my own with probably somebody that I want to hire from Upwork, because there's just a few other things that I tend to discuss. But an eczema action plan is probably the most appreciated and surprising thing that families talk to me about, because they've never heard of an eczema action plan before. And this gives them the sense of empowerment and comfortability with the treatment plan. So every day they're doing good moisturizers. Maybe they can use a cream in this phase, but maybe they need to use careful skincare products, maybe still eliminating the soaps and using cleansers. On my eczema action plan, I've actually changed this to include the TCIs and the PDE4 inhibitors when they're for more of a maintenance plan. And then when they have red itchy skin, I've developed click boxes for each of the medications. And I've broken this down into body parts. So the face with hydrocortisone, the body with triamcinolone, the thick areas on the body with fluocinolone, hands and feet, maybe they need some clobetasol. I've used the fingertip unit concept for understanding how much treatment to use per body per surface area. And then this section here, I've actually customized that to talk about bleach baths right here, moving into use of oral topical antibiotics if they need to, and then getting a hold of me in the red zone. So you could edit that yourself if you want to, but hopefully that's a really important piece of your systematic approach on how to develop a good educational plan and plan a workflow for yourself. This really saves you so much time. The next resource I wanted to point out was the Society for Pediatric Dermatology. So you may or may not be a member of the SPD. As a pediatric dermatology NP, I am only a pediatric nurse practitioner by my training. I don't have my FNP. So the SPD is my source of truth for with all of the derm nerds out there who work in pediatric derm, and they have really great resources that you can utilize. So you go to pedsderm.net. And if you click on the patients and families, you don't have to have a membership. And right here, I highlighted for you, they have so many different great handouts that are both available in PDF and Word, as well as I just noticed that they had some more educational videos there. So I would strongly recommend that you share this with your patients or utilize it for your practice, because they, at this point, have developed many different handouts that you could use alongside maybe your DermNets or your Visual DX when you're explaining or developing patient education handouts to give to your families. And after all that's said and done, then you really need to keep that momentum up. So communication is key, establishing a follow-up plan, but also with easy communication, reviewing photos as needed, and utilizing apps. So I do understand that you may be working at an institution that has really strict guidelines on what applications that you can use or not, being within their system and in their network. But if you're in a situation where you can utilize an app personally to communicate with your patients, then I strongly recommend this app. It's called PMD. It is a HIPAA secure app. I actually asked my patients to pay $25 for access to me through this PMD app, because patients can send me photos and ask me just generally tell me how they're doing. They could ask me for treatment recommendations. They could send me the picture of a skincare product and ask me if it's something that they could use. And some of you may be thinking like, oh my gosh, I would never give access to my patients in that way. I've done this with probably about 5 patients at this point. My practice just started to get revved up a little bit more in this year of June and July. I've never had a patient overuse it, abuse it. They ask it generally very reasonable times of the day. And they know that if my family comes first. So if they're asking me something in the evening or on the weekend, they may not hear back from me right away. But the reality of it is I could be sitting watching my kids do something, or sitting waiting for groceries to be brought to my car, because I'm that type of person. And then I could answer the question right away on P&D. They don't have to go through the MA or the nurse to get to me. And my patients are really happy with utilizing this. At first, I didn't have that fee, that $25 fee a month. And I felt like it was just too much of my time. But now with the 25, I feel pretty good with it. And down the road, if I get multiple patients sign on for $25, perhaps I need to have somebody else on hand to help me. But this is a great app that I found. And there's a way to also encourage discussion with maybe your referring in providers or those who you may be referring out to. So you could set that up with those consultants or referring people as well. And then I'm going to show you what the Eczema Wise app is from the National Eczema Association. So National Eczema Association has this really great app that if your patients are really interested in having something to help track their AD, taking photos, tracking their triggers, this is something that you could offer to them, as well as any of the National Eczema resources out there. I feel that they're very highly trusted, and they are primarily a patient advocacy group. So the insights that I've gathered from patients who are a part of NIA have been astounding in what they've given to me, not what I give to them, from just understanding those insights of a family or a person who deals with atopic dermatitis on a daily basis. So in summary, we established a holistic treatment approach to how to manage atopic dermatitis patients. Hopefully you'll be utilizing more infographics and handouts in your treatment plan. You're going to automate your practice to make it easy, reasonable for yourself and for your patients, and then hopefully be able to have some way of keeping an open communication with your families. I want to sincerely thank you for your time, not only for joining me and listening to me at nighttime wherever you live, but also just taking that next step to be able to want to learn more about how to manage these difficult patients with atopic dermatitis. And hopefully I gave you some new insights on how you can do that. We can open it up to questions now.
Thank you so much, Dr. Casselman. So I think we either can have you raise your hand, or if you want to type your questions into the chat box. Dr. Casselman, I'd like to start off by asking you a question. So I know that we were chatting before your presentation, and I mentioned to you that I work with adults, but they still have issues with using topical steroids. How do you counsel parents if that's something that you want to use? What kind of language do you use?
I first let them know that I never give them enough medication that I think could actually do them harm. So I only tend to give them one tube, knowing that some parents will milk that tube for a year. Also builds in the fact that if they're asking me for a refill in 2 weeks, that's a teaching point to tell them you're asking for a refill and that's not appropriate for the body surface area that we had. So that's one thing that I tend to tell my patients. And while TSW and topical steroid addiction and withdrawal, I feel is a legitimate thing that we have to worry about in our patients, I just let them know and be very honest. I don't know a whole lot about that as well. I do know clinical features that look like that may be something that we're walking into. But I find that so many patients have had discussions about TSW with other dermatology providers, and it's been completely brushed off. So I bring that up so that when they leave the appointment, they've heard the risk of TSW from me and not from somebody else, because just the same as if you don't talk about the black box warning on one of the TCIs and they hear it from the pharmacist, my credibility is going to go down if I don't acknowledge that there is something out there related to withdrawal. And that's why I asked you this question. So those are the two things that I tend to focus on, as well as just letting them know that I choose specific strains for specific reasons. So they should not be deviating from by using a triamcinolone on the face or by using the clobetasol all the time, because I tell them I know it's going to work the best, but there's a reason for why I put steroids in certain areas of the body. Most parents are really great. They don't abuse them. And like I said, they'll tend to milk the tube for 6 months. So there's no way they're overusing my prescription.
Martha, thank you so much. It sounds like Kimberly has a question. Are we able to open it up to her?
Yep, Kimberly, you should be able to unmute.
Can you hear me?
Yes.
Thank you. First, I want to thank you for your presentation. I really appreciate all the business pearls that you shared. My question is, how do you identify a HIPAA compliant app?
It usually will say it. It's also usually quite an expensive app. So that's why PMD is great, because they offer it for free. So it's just, I do simple Google searches. So I will be the first to admit that there are so many scheduling apps that you could use that aren't necessarily HIPAA compliant. So I would really stick within an EHR that has most of it built in. But yeah, Jot Forms has a HIPAA compliant forms, for example. If I didn't use the forms from my EHR, I use Cario right now. And you'll notice that you can have a free version of Jot Form, but the HIPAA compliant version is like $100 a month. So that usually cues you into the fact that it's HIPAA compliant, but then just doing a simple Google search too.
Thank you.
Yeah, you're welcome.
Dr. Casselman, I actually had one more question. So I often have patients who hope that there is one thing in their diet or one thing that they can eliminate and then eliminate the condition. How do you counsel patients and their parents on working with an allergist? When do you start to involve an allergist? How do you incorporate that into your plan?
So I'm really sensitive to referring early due to early introduction with allergies. So we used to have an algorithm at my old practice where they had spots available specific for babies who were under the age of 12 months. And that still kind of stands true. Anytime I refer a baby over, they get them in right away. So I don't feel that after about like 6 months or so, that's the appropriate age that you could start getting the babies over, especially for the early introduction. I do ask them if they have a specific trigger. If there's any sort of specific trigger, then I always refer them for that. But a lot of times they say that there's nothing specific that they've eaten, or they say that it's been citrusy items like tomato sauce, number 1 culprit, citrus, number 2 culprit. And there's nothing specific about it that they get in as far as an allergic reaction. And so then I focus on, well, if you eliminate something, then only eliminate one food for 2 weeks, monitor if it is better or not. If it's not, then you need to get that right back into your diet. So I end up talking about both type 2 and type 4 allergy responses with them. And I explain to them the foods, you need more exposures. The ingredients, you need less exposures. And so that really helps them to better understand that we live in different camps and there's different focuses with allergy. And when it comes to GI and, work up for say EOE or including a nutritionist, I just tend to try to grab as much information from trusted nutritionists who are pediatric nutritionists on say Instagram. And I utilize the tips that they have to funnel into my patients, because a lot of times it's just simple supplements, easy probiotics that don't increase histamine response and have been more successful with 80 patients. And then adding in like simple supplements like apple cider vinegar gummies into a young child's, that's not going to hurt them at all. So when it comes to referring to GI, I feel that it's a little bit trickier as well as a nutritionist because there aren't many GI focused AD providers. You're going to refer them and then they're not really going to know what to do with them. So I expounded a little more on your question, but
no, I really appreciate that. Thank you.
yeah.
Any other questions?
Not seeing any more at this time.
Okay, thank you so much, Dr. Casselman. I really appreciate your time and expertise. Thank you so much for working with us.
Yeah, I appreciate you guys having me. Patients can reach out on my website, and there's even going to be different tutorials that I'll go through that patients can sign up for, as well as I'll be reaching out to different states for licensure. So I'm in Hawaii, in Arizona. I will go to Hawaii and then choose 2 other states. So kind of keep posted on the website to see where I'm offering the availability to make appointments.
Great. So, thank you so much.
Thanks, guys. Bye.
Bye.